that is present illness, past illness, everything. All the panelists will ask the questions and clarify your doubts. And now and then we can clarify your doubts. And it will be an interesting case. So cardiovascular system as such, exam-oriented case, usually rheumatic heart diseases or any cardiomyopathy cases may be given. And once you pass over, usually acute coronary syndrome patients you will be managing, as well as congenital, non-congenital heart diseases, as well as pericardial effusion, constrictive pericarditis, everything you will be knowing. And as a postgraduate students, how to evaluate chest pain, dyspnea, palpitation, and how to differentiate between pericardial rub from pleural rub, everything you should know. And whether it's a purely pericardial effusion or associated pleural effusion also you should know. And when you are discussing about the cardiovascular system, for example, right heart disease, always rule out cardiac cirrhosis also associated. So as a complete physician, you should know in detail about the diseases and all the investigation point of view and management point of view. Our professors from Government Medical College, Thuthukudi, will be clarifying your doubts now and then. And our cardiologist Balamurugan also join. So over to the moderator, Dr. Rajavel Murugan, Dr. Arun Kumar, Dr. Balamurugan. Kindly take over the session, please.
Thank you, sir. We will start up with the session. Initially, the first case will be presented by Dr. Abhinaya, a postgraduate from Thuthukudi Medical College. Abhinaya, you can start.
Okay, sir. Shall I start, sir?
Yes,
Yeah, you can
proceed.
Here, a 72-year-old male patient, daily wages by occupation, hailing from Thuthukudi, belonging to lower middle socio-economic class according to modified Kuppasamy scale, came to medicine outpatient department with chief complaints of breathing difficulty for the past 3 months and palpitation for the past 2 weeks.
Okay.
Abhinaya, breathing difficulty for 3 months. Okay,
Yes,
as a
sir.
complete physician, what all the important thing you want to, what are the differential diagnosis? It's a chronic breathing difficulty.
Sir, for causes of breathing difficulty, it will be acute and chronic, sir. It's based on two. It's in a cardiovascular system and a respiratory system, sir. If acute cause for dyspnea will be acute pulmonary edema and heart failures will be there, sir. So cardiac cause for dyspnea will be, and patient will have left heart failure, or patient will have coronary artery disease and hypertensive heart disease and cardiomyopathies and shunt lesions and valvular lesions. These are the most common cause for dyspnea and cardiac cause for dyspnea, sir. If it's for a respiratory cause, the cause will be acute severe bronchial asthma.
Pericardial effusion, do you get dyspnea?
Yes, sir. We get pericardial effusion, we get dyspnea, sir.
Is that no? Yeah.
Yes, sir. For respiratory causes of dyspnea, it will be acute pulmonary embolism and acute respiratory distress syndrome. Our patient will have acute exacerbation of bronchial asthma and the COPD. And if patient of chronic pulmonary thromboembolism or respiratory causes for dyspnea, sir. Along with this, if patient have a chronic restrictive lung disease, like if a patient have parenchymal or extra parenchymal involvement, if it's parenchymal involvement, ILD will be the causes for dyspnea. If it's an extra parenchymal, Guillain-Barré syndrome or kyphoscoliosis will be the causes for, and myasthenia gravis is the causes for respiratory causes for extra parenchymal causes for dyspnea, sir. Apart from this, if it's an hematological cause, a patient with severe anemia with the failure will have dyspnea, and patient will have if it will be anxiety or hysterical hyperventilation, also the causes for breathing difficulties, sir.
Important thing, you have missed pneumothorax, acute cause.
Sir.
Pneumothorax or hemothorax or hemonepmothorax.
Okay, sir.
Abhinaya, actually, You have presented that as he is a 72-year-old male patient, daily wager by occupation. Usually,
Yes, sir.
occupation, you just mentioned what occupation that he did. Usually, a 72-year-old patient may not be doing much work now because of his
Oh,
age. So, you mentioned what occupation he did before and what, if so, he is doing now, what occupation he does now. So, that is very important because that says
okay.
about the exertional level of the patient. Usually, what the patients will say is that they were breathless for the past 3 months, so they will just ignore the previous breathlessness. So when does a patient come to a hospital? Only his daily routines get affected. They will come to the hospital. They won't be saying properly about the reduction in the workload that they have been doing previously. So maybe this breathing difficulty, this breathlessness, is of a chronic nature which would have been more than this 3 months. So any initial history, they would be very ignorant about those history. So you should prod more about that. For that, this occupational history will be useful. So you just mentioned what occupation that the patient was doing before, and if he is doing something now, some work now, you can also mention that. And I've been
Yes, sir.
saying about this lower middle socioeconomic class status. Oh, what are the
Okay,
scale?
sir.
You have said that is a modified Kupusami scale. What are the three criteria that the modified Kupusami scale uses?
So, education, income, and total per capita family
That is the
income,
income.
total per capita family income, sir.
Yes. So it says about it encompasses all. It
Uh,
says about the education status of the family
education
head. It says about the
and
profession of the family head, and also says about the per capita income of the
per
family.
capita income. Yes, sir. Yes,
So
sir.
it divides the whole society into 5 strata. One is the
By
lower
status.
class,
Lower,
upper lower, middle middle, lower middle, upper
lower
middle,
middle.
and high class. Okay.
Okay, sir.
So it divides into 5 strata. So why this socioeconomic status is very important in a cardiovascular system, please? So you're presenting
High
a cardiovascular
socioeconomic.
systems. Ah,
Okay, sir. Because high socioeconomic status, people are more prone to get dyslipidemia, cardiovascular, ischemic heart disease, and coronary artery
see,
diseases.
see, even lower middle class people get this kind of dyslipidemia and high cardiac risk. Okay,
And rheumatic
okay,
heart disease
proceed.
in lower.
Ah, ah.
Okay, sir.
So for your curriculum
Rheumatic heart
purposes,
disease.
the rheumatic heart disease is very important. The incidence of rheumatic fever is more so in underdeveloped and developing nations, that too with lower middle class and lower class peoples, and possibly
Yes, sir.
due to overcrowding. Okay,
Yes, sir.
it's true that the heart diseases, most importantly the myocardial infarction or any other diseases, going to get it is affecting the higher socioeconomic class status people more, but that was previously thought. Without the advent of this implosion of this non-communicable disease like diabetes and hypertension, more so in all strata of the society, now a myocardial infarction is generally what to say. It's generally it is spread over all strata of society. Okay,
Okay, sir.
okay. So this
And
lower social, sir.
yeah, breathing difficulty 3 months. Actually, Abhinaya,
Yes,
patient
sir.
was absolutely normal 3 months back. That word you have to use. Okay, that will clinch.
Yes, sir.
Actually, what Arun Kumar has told. Okay, usually COPD, chronic bronchial asthma patient, occupational lung disease patient, they'll be having a dyspnea. Maybe grade 1, grade 2, grade 3, grade 4. Okay, slowly progressive. So whether the patient is absolutely normal 3 months prior, so you should put a leading questions. So any respiratory dyspnea or a cardiac dyspnea, it may be acute or chronic or acute and chronic. Okay. So always
Okay, sir.
patient was absolutely normal 3 months back. So previously lost 72 years. He is living for the 72 years. 3 months back, patient was absolutely normal. Whether that history is very important. Socioeconomic status also very important. Yeah. He can, because always acute cause, chronic cause, as well as acute and chronic. You should include. Okay. Because the
Okay, sir.
decompensated heart disease maybe for a past 10 years or 5 years. Now exaggeration may be there. Okay, for that reason only, whether the patient was absolutely normal. That yeah, you can proceed.
Abhinaya,
Okay, sir.
Abhinaya,
Sir?
this socioeconomic status not only says about the etiology, it may not lead to the etiological history, but also it says about the treatment modalities. Because you can plan your
Okay, sir.
treatment accordingly, whether it is a higher strata or a lower strata, how well the patient will be compliant with the drugs that you are prescribing, and for any surgical indications that the patient may accept. So that is very important both for the etiological point of view as well as from the treatment aspect of. You can proceed.
Okay, sir. Okay, sir. And history of presenting illness. Patient was apparently normal and performing his daily activities 3 months before. After that, he developed breathlessness on exertion. It occurred on climbing 2 flights of stairs, which was able to climb previously without any difficulty. That is according to class 2 NIGA. After that, it progressed. Now, it patient had breathlessness even on walking on the level ground for the first few minutes. That is in class 3 NIGA. It's not associated with worsening of dyspnea on lying down, and there is no paroxysmal nocturnal dyspnea, sir. And follow that patient have palpitation for the past 2 weeks. It's a regular. It's occur on daily basis on exertion and is reduced by taking this. Palpitation is not associated with the diuresis or a syncope or not associated with the neck pulsations, sir.
Okay. So you have classified this patient's dyspnea according to New York Heart Association.
Yes, sir.
Okay. What are the other symptomatology that can be classified using New York Heart Association classification?
Sir, palpitation, angina, and fatigue, sir.
Then you haven't classified
Except the
palpitation.
syncope.
You haven't
Yes, sir.
classified palpitation according to NIHA then. So you should also classify
Uh,
palpitation according to NIHA. Okay.
palpitation and
Right. So the patient was apparently normal and performing his daily activities. Okay. 3 months back.
sir.
Now
Yes,
the
sir.
dyspnea has progressed to certain level that he is not able to do even a less than normal activity. Okay. Palpitation.
Yes,
Why do
sir.
you want to say about the regularity in the palpitation?
Sir,
You mean to
if
say
it's
it is
irregular,
irregular? You mean to say it is irregular or persistent? There's a difference.
it's in a regular and persistent, sir.
Oh, regular and persistent. Okay.
Regular and the persistent which occurs on daily basis on exertion, sir, and it's
Okay,
reduced
okay.
by taking rest.
So this is a persistent palpitation that has been occurring for the past 2 weeks. And
Yes,
previously, he didn't have any palpitations with the previously.
no, sir, it does not give any history of previous history of palpitation, sir.
So how was the palpitation? The onset of palpitation is also very important. Whether it was an acute onset or a so insidious onset palpitations. So any psychosomatic palpitation, any psychological anxiety-induced palpitations, or any arrhythmia, that is any tachycardia-induced palpitations, they may be acute in onset. Okay.
Okay, sir.
And persistent palpitations, what do you think about the persistent nature of palpitations?
So if patients have an anemia and hyperthyroidism or a recurrent episode of hypoglycemia and patient on generalized anxiety and if the patient on drug induced like alcohol or alcohol or emotional stress, these are the condition of patient get palpitation on regular basis, sir.
So what are the cardiac causes of persistent palpitation? What you are saying is not cardiac causes.
Congenital heart disease and cardiomyopathy, sir, and mitral valve prolapse. And
any volume overload condition producing an LV or an RV volume overload, the patient may get palpitations. It may be a myocardial infarction related, dilated ischemic dilated cardiomyopathy, it may be a mitral valve induced cardiomyopathy, dilated cardiomyopathy, or it may be a asynotic congenital heart disease induced like VSD, PDA. So any volume overload condition is going to produce an eccentric hypertrophy in your heart, and it is going to be a cause of persistent palpitations. Okay. And you have asked about association with neck pulsations and all. Why?
Sir, if it's a patient of paroxysmal supraventricular tachycardia, it's associated with the neck pulsation, what we call the frog signs in SVT, sir.
Okay, very good. So why do you want to ask about diuresis or syncope?
Sir, if the patient have post-ventricular tachycardia, the patient will have a release of atrial natriuretic peptides. So that may leads to diuresis.
That may not be happen often. Then why do you want for why did you ask for syncopial attack?
As to look for any premature atrial and ventricular contraction and
In
to
other
look for
words,
arrhythmias, cardiac arrhythmias,
any cardiac asystole, Stoke
cardiac
Adams
arrhythmias.
syndrome. Okay, any cardiac asystole, Stoke Adams syndrome. Okay, and then
Yes, sir.
if the patient is complaining of diaphoresis and episodic palpitations, what will you think of? The patient complaining of episodic.
Pheochromocytoma, sir.
Very good,
Endocrine,
very good. So you should think of
pheochromocytoma.
any individual who is having episodic palpitations or diaphoresis and episodic hypertension. You will think of pheochromocytoma. Okay, right.
Okay, sir.
Okay.
Actually,
So
most
this
of
patient he was not associated any paroxysmal nocturnal dyspnea or orthopnea.
yes, sir.
Okay.
There is no history of PND and no history of orthopenia, sir.
Okay. 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 So how do you define episodes of PND?
Sir, it's I define as a sudden onset of breathing difficulty which occurs 2 to 2.5 hours after the patient went for bed. So if patient went to bed normally, after that, after 2 to 2.5, after the 2 to 3 hours, the patient develop breathlessness, sir.
Okay.
Breathless, the patient wake up from the sleep and they this breathlessness relieved when the patient went to the window or sit ups with the legs hanging down or stand up with the air hunger or self ventilates by himself, sir.
What does it signify? Paroxysmal nocturnal dyspnea.
Sir, it's what signifies means if the patient went to sleep, patient initially on NRM, sir. After that, over 3 hours, a patient went for REM sleep. While during REM sleep, there will be an sympathetic overactivity during REM sleep, and follow that there will be a depressed respiratory center, sir. All this which leads to tachycardia. Whenever tachycardia will be occurs, follow that pulmonary, which leads to if it's a patient on cardiac failure, left ventricular volume overload will be there. After that, the pressure will be transferred to left atrium. For all that, there will be this pressure transmitter to pulmonary venous system, pulmonary artery system, and to pulmonary capillaries, where the pulmonary interstitial congestion will be occurs, which may leads to edema, sir.
No, in other words, simply you are saying the whole pathophysiology
Simply
begins
words, it's an
paroxysmal.
increase in pulmonary capillary wedge pressure, sir. Simple words, it's
In
due
other
to
words,
pulmonary capillary wedge pressure, sir.
we say impending left ventricular failure. Very simple.
Yes, sir.
So paroxysmal nocturnal dyspnea implies an impending left ventricular failure. If the ventricles have failed, the ventricle has failed, the patient will be having orthopnea. Okay. So you were talking about the REM sleep and an increase in sympathetic activity. More so, the shifting of fluid from the interstitium into the intravascular compartment offers more pathology in paroxysmal nocturnal dyspnea. So it is the main reason. 90% of paroxysmal nocturnal dyspnea occurs due to the shift of the fluid from the interstitium to the interstitial compartment to the intravascular compartment. And also, as you said, there is a depression in the respiratory center, and more so, the on lying, the effect of gravity is eliminated, and your diaphragm moves above, and there is posterior splinting of your ribs. So all these contributes, and they have a superlative effect to produce an exudation into the alveoli. That is where that causes the paroxysmal nocturnal dyspnea.
Okay,
So it is very important that you prod for the history of paroxysmal nocturnal dyspnea, because that may be the clue differentiating a cardiovascular from a respiratory dyspnea more so often. Okay. Once the patient develops orthopnea, you will be knowing that the patient has some cardiovascular problem, a cardiac cause. So the history of paroxysmal dyspnea occurs once or twice only in the entire course of the disease. So once the left ventricle has failed, naturally the patient will be having orthopnea.
Okay, sir.
Right. Okay. You can proceed. So the patient was on progressive dyspnea along with persistent palpitation. So that is the thing that we can take from this presently. Okay.
Yes, sir. patient had a history of easy fatigability for the past 2 weeks and no history of chest pain, no history of orthopenia, no history of paroxysmal nocturnal dyspnea. Patient had no history of trypopenia, platypenia, benlopenia, no history of syncope and no history of cough with expectoration, hemoptysis and no history of fever, sir.
Oh, this history of easy fatigability, what does it signify
Uh,
in a cardiovascular
sir,
system?
sir, if a patient have a fixed cardiac output, sir, when patient with have a fixed
In
cardiac
other
output
words,
while during
simply saying the patient is not able to maintain an optimal cardiac output for a given work or for a given exertion, which means that it could be either due to the pump dysfunction or the pipe vascular dysfunction. Okay.
Sir.
So easy fatigability. Fatigue is a very important symptomatology with regards to cardiovascular system. You should also ask more leading questions about fatigability, because most of the patients, as I said before, they will be ignoring the previous histories, the previous intolerance to any work. So exercise intolerance and the fatigue are more important rather than this dyspnea and palpitation and other cardinal signs, symptoms of heart diseases, because these are the earliest symptoms that can pick up the heart disease at the early point. Given so, in a developing country like India, fatigues and exercise intolerance occurs more so with what disorder? Anemia rather than any
Anemia,
heart
sir.
disease.
Anemia, sir.
So you should rule out first anemia, and then you think of an cardiac cause.
Okay, sir.
All right.
Yeah.
So what may be the cause of chest pain with regards to any cardiovascular system?
Sir, coronary artery disease, ischemic heart disease is the most common cause of chest pain, sir. Following that, a patient have if the patient with pericarditis or invalvular heart disease, mitral valve prolapse or aortic stenosis is the most common valvular heart disease which may cause chest pain, sir. Following that, mitral regurgitation. These are a cardiac cause. If when we went for a vascular cause, it's a dissection of aorta is the most common cause for chest pain in returning to vascular causes, sir. If it's pulmonary embolism and pleuritis and the pneumonia is the most common cause. Apart from this, gastrointestinal cause will be diffuse esophageal spasm or peptic ulcer disease. And if the patient will have shingles like zoster over the chest.
No. Just I'm asking
Okay,
what
sir.
may be the causes from a cardiovascular system. You can divide it into an ischemic cause and a non-ischemic cause. So non-ischemic cause, you said like pericarditis, pericarditis or aortic dissection. It may be due to non-ischemic cause. Ischemic cause you can divide into either due to MI related cause or valvular related cause or pump related, that is ventricular, the heart muscles related cause. It could be due to hypertrophic cardiomyopathy, or it could be due to valvular heart disease like aortic stenosis, or it could be due to an ischemic heart disease like your myocardial infarction or chronic stable angina. So any cardiovascular system chest pain, you can divide into an ischemic and non-ischemic. Okay. So you can just differentiate the symptomatology like that. Okay.
Okay, sir.
Okay.
Shall I move to next slide, sir?
You go. You can move to the next slide.
Okay. And patient had no history of bilateral leg swelling and no history of abdominal distension and no history of facial puffiness and no history of decreased urine output and no history of abdominal pain and no history of cyanotic episodes and no history of recurrent respiratory tract infection and no history of sore throat, no history of skin manifestation and involuntary movements and no history of loss of weight, sir.
You're asking about bilateral leg swelling, okay, abdominal distension, okay. Why do you want to ask those histories? See, whenever you present a system, whenever you present a particular system, you just first go through the cardinal symptomatology of those systems. So the previous slide you said about fever, since so
Sure.
fever, and then go to the previous slide. So fever, cough with expectoration. So that should come after bilateral leg swelling, because pedal edema is an one important symptomatology of cardiovascular system. Okay. Right. You can go to the next slide. Now, why do you want to ask about this bilateral leg swelling and abdominal distension?
Sir, to rule out right-sided heart failure, to rule out congestive cardiac failure, right
So
heart
to
failure.
rule out an volume overload condition, possibly due to a congestive heart failure. Now, how does this abdominal distension and bilateral leg swelling help to differentiate between other cardiac and other volume overload conditions?
So to look for whether leg swelling is unilateral or bilateral, sir. If
No, actually bilateral
unilateral,
only, volume overload condition, there will be bilateral leg swelling. It could be either to dysfunction of three major systems, that is your cardiac, liver, as well as your renal system. Now, will this help, this history of abdominal distension, bilateral leg swelling, help in differentiating what system is mainly affected? Yeah, said
so the
about puffiness of the chest.
evaluation of edema, sir. How the edema will be progress, how will it start, and
Very good.
which
So
is the
how,
first involved in the
which happens first? That is very important. Okay. So usually in a abdominal distension, while in hepatic cause, the abdominal distension will be followed by pedal edema. There is one cardiac cause where abdominal distension will precede pedal edema. What is that?
cardiac precox, sir.
Huh?
Constrictive pericarditis.
It is
Sir,
constrictive pericarditis. It is known as ascites precox. Okay. So that is the condition where your abdominal distension will precede pedal edema. And remember, as my chief says, for pedal edema to happen, there should be at least a few liters of fluid in your legs. So it is a sort of a last stage where most of your myocardium has become dysfunctional. Okay, that's why I'm asking you. I said the symptomatology of fatigue as well as exercise intolerance is very important. And then once you finish the cardinal symptomatology of the cardiovascular system, you go for a right heart failure symptoms as well as left heart failure symptoms. As you said, decreased urine output. Oliguria is one important feature of left heart failure system, because the kidneys receive a major portion of your cardiac output. Okay. Okay.
Okay, sir.
Abdominal pain in cardiovascular system, where you can get. You have asked about abdominal pain. There is no history of abdominal pain. So abdominal pain
Sir,
in cardiovascular
tender
system.
hepatomegaly, sir. Patient
Very
with
good.
congestive hepatopathy, sir.
Very good. So whenever there is an stagnation in the right heart, there will be a congestive hepatopathy. There will be a stretching of the capsule of the liver, Glisson's capsule, and it will produce a pain over the right hypochondrium.
Yeah.
And then any other thing you can think producing abdominal pain, any mesenteric ischemia possibility?
Aortic aneurysm and mesenteric ischemia, sir.
No. Why does
Or
aortic
if
aneurysm
it's
cause any mitral valvular heart disease causing mesenteric ischemia due to any problem, any complication?
AF, sir.
So any atrial fibrillation dislodging a thrombus and it is going and sitting itself in a superior mesenteric artery, which proceeds mesenteric ischemia. So that way the patient can experience abdominal pain in a cardiovascular system cause. Okay.
Okay.
So I have been asking about cyanotic episodes. Will the 72-year-old Tata remember about cyanotic episodes?
Sir, to rule out congenital heart disease, whether it's
that you would ask in the past history. Okay, recurrent. How do you define recurrent respiratory tract infections? What is the criteria that you will have hold to say that the patient has had recurrent respiratory tract infections?
3 episodes.
Very good.
In
3
a year.
episodes. 3 episodes in a year. 3 episodes in a year treated as an inpatient, or 6 episodes in a year treated as an outpatient. Now, why do you want to ask about what is the main pathophysiology behind recurrent respiratory? What does it say? So any
pulmonary
right to left
congestion,
side,
sir. Sir,
Any right
pulmonary congestions.
to left shunt, you will have cyanotic episodes. Left to right shunt, you will be having recurrent respiratory tract infections. Okay.
Okay, sir.
Why the history of sore throat is very important?
Sir, rheumatic etiology, sir.
Yes. So, what is the main organism implicated in rheumatic fever? Or the only organism?
Streptococcus, sir.
Oh, say it
Group
fully.
Group A beta hemolytic streptococcus, sir.
Group A, beta hemolytic streptococcus. Okay.
Streptococcus aureus.
So every rheumatic fever may not be preceded by sore throat, and all sore throat may not be followed by a rheumatic fever. But still, this history is very important in an Indian setup to ask for an sore throat, because in an endemic nature, this streptococcal infections, while they are endemic like in India, they may not be so well associated with glomerulonephritis or rheumatic fever. But when there is an epidemic proportions in developed countries, when there is an epidemic of this beta hemolytic streptococci, definitely it is followed by some amount of glomerulonephritis as well as rheumatic fever. So that is very important. And also skin manifestations.
So look for erythema marginatum in rheumatic fever, sir.
Erythema marginatum. Whether this male patient was a dark skinned or a fair skinned.
If the patient have infected endocarditis, to look for a osseous node
Very
and a
good.
Janvier lesion, sir.
So impetigo may also be caused by streptococcus. You should also look at that. So for even that, you can ask for skin manifestations. Right.
Okay, sir.
History of loss of weight, loss of appetite. Where does it happen? How does it happen in a cardiovascular system?
So if suppression of hepatic center, sir.
No, why do you want to suppress the appetite center? How does it suppress the appetite center?
Because if
Say,
the
what is
patient
cardiac
have
cachexia?
malignancies, or if a patient have myxomas,
No, don't think too much. So what is cardiac cachexia? So any chronic cardiac disease is bound to produce loss of weight. That is cardiac cachexia. Why there's a loss of appetite happens in the cardiovascular system case?
because of inflammation, rise of increased interleukins.
No, we don't go into molecular level.
So if
Just
yes, sir.
think simple. It could be due to a congestive gastropathy. Okay. And drugs like digoxin may produce anorexia. The digoxin was a favorable drug, was a favorite drug for a decade before for all cardiac conditions. I mean, the non-contractile cardiac conditions, decompensated heart diseases. So it used to cause anorexia. Okay. So cardiac cachexia, it may produce loss of weight, and loss of appetite may be due to congestive gastropathy as well as drugs like digoxin.
Okay, sir.
Okay. And proceed.
Okay, sir. In past history, patient diagnosed to have systemic hypertension 2 years before, and the patient started on treatment, but patient took irregular treatment. Last intake of drugs will be 6 months before, and the patient stopped hypertensive drug by its own self, sir. And patient had no history of diabetes mellitus, or no history of coronary artery disease or pulmonary tuberculosis, and no history of chronic obstructive pulmonary disease or bronchial asthma or seizure or thyroid disorder. Patient have no history of fever with migratory large joint pain in childhood, or taking once every 21 days injection, and no history of sexually transmitted disease, and no history of any surgery in the past, sir.
Very good. So, Abhina, you asked about sexually transmitted diseases. We will come
Yes,
to
sir.
that later. So, you say
Yes, sir.
that the patient is in known hypertensive for the past 2 years, but he has not been taking drugs for the past 6 months. Okay.
Yes, sir. Yes, sir.
So, this is a very important point where the patient may be present to you with an breathlessness and palpitations.
Yes.
Whether the systemic
Yes, sir.
hypertension could be a possibility. If in the etiology
Yes,
for
sir.
that breathlessness, definitely. Okay,
Yes, yes, sir.
because the most ignorant symptom that we ignore as well as the patient ignore in a systemic hypertension is a dyspnea. Okay, so a patient comes to you with a class 1 dyspnea, you evaluate for him everything. At last, we find the patient is having a left ventricular hypertrophy and echo. Is a known hypertensive. So when you start to treat the hypertension, if the left ventricular hypertrophy resolves to some extent, definitely the dyspnea will resolve. Okay, so that is very important one symptomatology of hypertensive heart disease. So more so often we are more concerned about the heart failure with reduced ejection fraction rather than a heart failure with a preserved ejection fraction. And your systemic hypertension constitutes a major chunk of etiology for the heart failure with preserved ejection fraction. And definitely you should look into all patients that you look, hypertensive patients that you look for this high preserved ejection fraction, heart failure with preserved ejection fraction. Okay.
Yes, sir.
So I asked the history of rheumatic fever for migratory large joint pain.
Yes.
Whether you
Yes,
think
sir.
that this rheumatic fever occurring in a childhood is leaving the patient until his 8th decade and it could cause rheumatic heart disease. Because
No, sir.
previously the patient didn't have any kind of symptomatology or any kind of previous admissions in any hospital or anything. He wasn't able to
No, sir.
remember.
No,
So
no,
he
sir.
wasn't able to remember, which means that it may not be a major, even if it had been admitted, it would not be a major disease. Okay. So actually, for this to be a rheumatic etiology is very rare. Okay.
Okay, sir.
Okay. So why do you want to ask about sexually transmitted diseases?
Sir, to rule out if the patient have syphilis, then more prone to get aortic regurgitation or coronary arterial stenosis that may
Very,
lead to chest pain, sir. Syphilis, to
very
rule out syphilis, sir.
to rule out syphilis, but you will ask, how will you directly ask the patient like this? What history did he ask to say that they had no history of any sexually transmitted disease?
To look for any ulcers in the genital area, sir,
Very good.
or a
Okay.
painful ulcers in the genital areas.
Very good. So you should ask about the sexual promiscuity as well as ulcers in the genital areas. Okay.
Okay, sir.
Right.
Shall I move, sir? Shall I go to?
So just for the sake of rheumatic fever, mostly this slide, just for sake of rheumatic fever to refresh your knowledge, what is the criteria for rheumatic fever that you
Jones criteria,
find out?
sir. Jones criteria for
Jones or modified Jones?
modified Jones, sir.
So how recently that criteria has been modified, and what is the criteria?
Sir, in 1992, it will, sir,
No,
it will be,
recently they are divided into high prevalent and low prevalent areas. On
yes,
what
sir.
basis they are divided into high prevalent and low prevalent?
Based on the prevalence of, based on endemicity or prevalence of cases in that area, sir.
No, it is based on the
Or based
prevalence
on the
of. It is
school-going
based on
children,
the. It is based on the
based on the,
incidence of rheumatic heart disease in school-going children as well as incidence of rheumatic fever in a general population. Okay, so in that way they are dividing into high prevalent and low prevalent area. And what one important criteria, one important change in the criteria between high prevalent and low prevalent in the major criteria. What is that? So usually what you will say, usually saying migratory polyarthritis involving the large joints. But in
so instead
high,
of arthritis, arthralgia.
very good.
Arthralgia
Arthralgia
we
means,
keep it.
okay. So in high prevalent societies like India, where the incidence of rheumatic fever is more than 1 in 1 lakh population, or incidence of rheumatic heart disease more than 2 in 1,000 school going children, what they take is that they take even a monoarthritis as a major criteria or even a polyarthralgia as a major criteria. So only monoarthralgia will be a minor criteria. Can you understand? So previously,
Yes,
the
sir.
polyarthritis was a major criteria for all. Now, in a high prevalence area, even a monoarthritis or a polyarthralgia is taken as a major criteria. Keep it in mind. That is very important. Okay. And
Okay,
even
sir.
a ESR of more than 30 mm after 1 hour is considered to be a minor criteria. So these are all very important certain modifications that has happened with this rheumatic fever. Okay. And
Okay, sir.
define this polyarthritis of rheumatic fever. So
So it's
as you
a
say,
flipping and a fleeting type of arthritis which involves large joints.
very good. So
And
it is
it's
migratory polyarthritis involving the large
arthritis.
joints, which responds to high dose aspirin and leaves no residual deformity on healing. Okay. So this is
Okay,
very
sir.
important. So it doesn't leave a residual deformity, and it is very much receptive. Very much it resolves with high dose aspirin. What is the differential diagnosis for a rheumatic arthritis, polyarthritis?
For a Jacob's arthritis, sir, that's
Very
an
good.
ulnar deviation of fourth and fifth finger with
Very
flexion with
right.
metacarpal phalanges.
What is Jacob's arthritis? Why does it happen? It is also a post-streptococcal reactive arthritis, where you may not have where the arthritis may not resolve with high dose aspirin. But still, it also doesn't leave any deformities because that is only due to subluxation of the joints rather than the joint involvement itself. So even Jacob's arthritis, there won't be any deformities after a few months, but it won't respond to high dose aspirin. So it is an important differential for rheumatic polyarthritis. Same one infectious disease where you will be getting migratory polyarthritis. So vector-borne disease.
Dengue, sir. Lyme disease
Very
and
good, very good. Very good.
Lyme disease.
So that is an important point in Lyme disease where you will be getting migratory polyarthritis. Okay. So whether carditis is more common or arthritis is more common in rheumatic?
Arthritis is the most common, sir, compared to carditis.
Arthritis, more than 80% the patient be getting arthritis. Now, how about carditis?
50 to 60%, sir.
Very good, 50 to 60%. Now, whether you can say about carditis, or is there any other extension of this carditis which could be detected through echo? In other words, now at present, rheumatic fever is not only about carditis, it is also about subclinical carditis, which can be picked up with echocardiography. Okay. Right. What may be the what is a very important one word describing this carditis in rheumatic fever?
Pancarditis, sir.
Very good, very good. Pancarditis. So it involves all the three layers of the heart. Pancarditis. Okay. Right. What are the other major criteria?
Subcutaneous nodules and erythema marginatum and symptom scoria, sir.
Very good. Where do you look for this subcutaneous nodules?
So over the bony prominence like elbow, chins, occiput are extensor surface.
Right. Okay. Okay. So you're talking about the skin manifestation. Erythema marginatum is very specific for rheumatic fever as well as rheumatic. It may have the more those individuals with the skin manifestation, the erythema marginatum may be have more propensity to develop rheumatic heart disease. That you have to keep in mind. Right. I can proceed to the next slide.
In personal history, patient consume mixed diet. He's a smoker for the past smoker since 20 years of his age. He takes a BD, that's a once packet per day, and he stopped 10, it's 40. And patient is not an tobacco chewer, not an alcoholic. Sleep was normal, appetite is reduced, and a bowel and bladder which were normal, sir.
Okay. So what is the importance of smoking over this patient?
Atherosclerosis will be more common, which may lead to ischemic heart disease.
Accelerated atherosclerosis. So it is a major risk factor for accelerated atherosclerosis. It is one of the modifiable risk factor. Okay, that is very important. It is one of the modified risk factor for us accelerated atherosclerosis. Right. Can go to the next slide.
Family history, no history of similar complaints in the family members, and no history of engaged death in family members. Treatment history for the above mentioned complaints, patient went to nearby local hospital 6 days before, and he got evaluated and got referred here for a cardiology opinion, sir.
Okay, you go for summary. You summarize this.
Here, a old age male with known systemic hypertension on irregular treatment with smoking history, presented with progressive dyspnea, progress from grade 2 to grade 3 NIGA with exertional palpitation and easy fatigability. Based on the history, the problem system involved is cardiovascular system, which is an acquired cardiovascular disease.
Right. He is having a progressive cardiovascular involvement as evidenced
Yes, sir.
with progression of dyspnea, palpitations, exertional palpitations, and easy fatigability. Okay.
Okay, sir. Shall I move, sir?
Yes.
Sir, on general examination, patient comfortable at rest, conscious and oriented to time, place, and person. It's afebrile, hydration status were normal. Height was 156 centimeter, weight is 48 kilogram. Body mass index will be 19.7 kilogram per meter square. And patient is paler, no jaundice, no clubbing, no cyanosis, no pedal edema, no significant lymphadenopathy, sir.
What do you think the cause of pallor in this patient? No, you
Sir,
don't think think in terms of a cardiovascular disorder. A 72-year-old male patient has presented to you with pallor. Why? See, pallor has two sides. One, it could be due to his cardiac problem, or this presence of pallor may exacerbate the already present cardiac condition. Okay, maybe that's why he has gotten breathing difficulty now, breathlessness now. Can you understand what I am saying? பேலர் இருந்தாலும் பேலர்னால பிரச்சனை வந்திருக்கலாம், இல்ல முன்னாடி இருந்த பிரச்சனை வந்து பேலர்னால எக்ஸாஜர்பேட் ஆகிருக்கலாம். சரியா? ஸோ இன் திஸ் பேஷண்ட் ஒரு 72-year-old மேல் பிரசன்டிங் டு யூ வித் பேலர். இந்த கேஸன் விட்டுரு, ஒரு 72 வயசு தாத்தா வந்து பிரசன்ட் டு யூ வித் பேலர். வாட் வில் யூ திங்க் ஆஃப்?
Sir, if it's a male patient, pallor associated with clubbing, we think of malignancy, sir. Or if the patient with the previous history of CAD, which taking aspirin or clopidogrel, the more prone to get pallor, sir. Or any left ventricular outflow tract obstruction, which may lead left ventricular outflow tract obstruction, which may leads to
any old age
pallor.
individual presenting you to pallor, just main two causes. One is
anemia of chronic disease.
One is due to nutritional anemia. Other thing is the anemia due to chronic disease or anemia due to chronic blood loss in the GI tract. They have to first evaluate for that. Now coming on to this case, a case of cardiovascular system disorder presenting with pallor, what could be the causes? How do you correlate pallor with valvular heart disease? In other words,
if patient with infected endocarditis patient, one of the markers will be pallor, sir. Or
it is not a marker. One of the feature in infective endocarditis will be pallor. Okay.
Or left ventricular outflow tract obstruction, which may decrease LV output, which may lead to
there
pallor,
are only
sir.
two reasons for being pale. One, either the patient is anemic or the patient is in shock. Okay, both the conditions the patient may be pale. Okay, so any valvular heart disease causing anemia, what are the valvular heart disease? In other words, what are the valvular heart disease causing anemia?
Aortic stenosis.
Okay, how does aortic stenosis cause anemia?
Decreases stroke volumes, decreases cardiac output.
No.
Because it
How does
decreases
how does aortic stenosis cause anemia? In other words, it produces some sort of hemolysis. Okay, constant hemolysis. Okay, you say what are the conditions where you can get pallor in a cardiovascular system case? What are the reasons for pallor in a cardiovascular system case? You leave valve or heart disease. You can say
so
anything.
if mitral stenosis we get mitral stenosis we get pallor, sir. Or if a patient with underwent any prosthetic valve surgery, due to that we get a hemolysis that may leads to pallor, sir.
Okay, very good.
And um, AS will cause pallor, infected endocarditis will may cause pallor, or if pallor but the subacute bacterial endocarditis.
No, that you said before. No, one pallor could be due to this chronic malnourishment. Okay, pallor could be valvular heart disease due to valvular heart disease like aortic stenosis, where we have the shear stress on the RBCs getting hit against the stenosed valve may itself cause hemolysis, and there could be a constant hemolysis, and there can be pallor. And the aortic stenosis can be associated with an angiodysplasia of colon, which you call it as an Hades syndrome, where you can have constant loss of RBCs from the GI tract. You can have pallor. And then, as you said before, this prosthetic valves. This prosthetic valves previously it was not biological valves; it was a mechanical valves where the RBCs would get hit and become lysed, so it can produce pallor. Okay, so these are the conditions where pallor may be associated with cardiovascular system. And more so often, due to this chronic malnourishment, due to a low cardiac output state like a dilated cardiomyopathy, anemia will be always a coexistent factor with a dilated cardiomyopathy. It may worsen the cardiomyopathy itself. So that is very important, pallor.
Okay, sir.
Where do you get clubbing in cardiovascular?
Infected endocarditis.
Okay.
Cyanotic
Infective
congenital heart disease we
endocarditis,
can get.
whether you get clubbing in acute infective endocarditis or a subacute infective endocarditis.
Subacute endocarditis we get
Very good.
clubbing, sir.
So in acute infective endocarditis, you won't be getting any clubbing. And one important feature about clubbing is in subacute infective endocarditis, it is one of the cause for transient clubbing. Once the infective endocarditis is resolved, the clubbing will also resolve. Okay. So what are the other heart diseases where you will be getting clubbing?
Cyanotic heart disease, sir. If cyanotic heart disease, we can get clubbing the cyanotic heart disease with shunt lesions.
Right. Cyanotic heart disease, you will be getting clubbing. Say me if you know.
And
say me one.
if a patient with atrial myxomas or if acyanotic heart disease patient went in for a ACE mingration, also get clubbing, sir.
Right. Congenital heart disease and acyanotic heart disease. If you have a myxoid tumors in the left
ACE
atrium,
mingration.
you can get an clubbing. Okay.
Clubbing,
Right.
sir.
Right.
Or if patient with PDA with reversal of shunt also we get
Right.
clubbing,
Okay.
sir.
Okay. That is easy in Mangas.
Okay, sir.
Why height is important in a cardiovascular system patient?
Sir?
Height.
Sir, to look for a Marfan, sir. If the patient if in a Marfan patients, mitral valve prolapse or mitral regurgitation is more common, sir. So height is for to look for Marfans.
Okay. What is the criteria that you use for Marfan's diagnosis?
If height is more than 180 centimeters or
I'm asking about
Gens criteria, sir.
That is Gens criteria. GHENT. Gens criteria.
Yes.
Where it encompasses all the features of Marfan, not only musculoskeletal, but it will also encompass cardiovascular system. It will also encompass your eyes, everything else. Okay. Right.
Okay, sir.
Proceed.
Patient had no markers for congenital heart disease and no markers for infected endocarditis and no markers for tuberculosis and no markers for HIV and no markers for rheumatic heart disease, sir.
Now, if you are looking for, you are presenting a case of aortic regurgitation. Is that so?
Yes, sir.
No.
It's
When-
AR with MS.
Then what other markers that can look into?
Looks for coronary artery disease, sir. And peripheral signs
Look
for
for marks
AR,
of-
sir. And syphilis markers for syphilis
Markers.
and
Very good.
marker for coronary artery disease, sir.
In other words, markers of atherosclerosis.
Yes, sir.
What are the markers of atherosclerosis?
Sir, Arcus analysis.
You just go to the previous slide. You just go to the previous slide.
Yes,
Right.
sir.
You can go to the next slide.
Okay, sir.
So whether you
Sir,
have put in the upcoming slide about atherosclerosis, markers of atherosclerosis? No. Okay. Okay.
no,
You say
sir.
about markers of
Sir.
atherosclerosis.
Sir, markers will be earlobe creases will be diagonal, xanthelasma, xanthomas, and arcus analysis.
Very good.
And if obesity and if and a nicotine stain or finger and teeth, sir. If patient was a smoker, chronic smoker, it's like the tobacco users will for nicotine stains and the finger and teeth, sir.
So what is xanthelasma? It is a marker of atherosclerosis. What is xanthelasma? Where do you look for xanthelasma?
Over the tendon, sir.
No, xanthelasma. That is xanthomas.
Xanthelasma
you will be
medial
looking.
canthus.
You will look at
Medial
the inner
canthus of
canthus.
eyes, sir.
Inner canthus of the eyes.
Eyes.
And what does tendon xanthoma specifically say about? What are the types of xanthomas that you know? It's a collection of fatty substances, xanthomas. What are the types? What are the areas where xanthomas you can find? One is, as you said, tendon xanthomas. Now, tendon xanthomas are very specific. They are mostly associated with hypercholesterolemia. While here, eruptive xanthomas or eruptive xanthomas, they are mostly associated with hypertriglyceridemia. One is tendon xanthomas associated with hypercholesterolemia, while here eruptive xanthomas are associated with hypertriglyceridemia. Okay. What are the other types of xanthoma that you know?
Xanthoma planum or Palmer xanthoma, sir.
Very good. Palmer xanthomas.
Xanthoma tendinosum.
That is an tendon xanthomas.
And
Right. You should also look for the
tuberoeruptive xanthomas.
And you should also look for collagen vascular disorders. Not in this case, but still, when you present a case of aortic valvular heart disease, you should also look at the collagen vascular disease, because the most common cause, one of the most implicated cause of chronic aortic regurgitation is autoimmune disorders, the collagen vascular disorders. Okay.
Okay, sir.
Right.
Sir, shall I go to next slide, sir?
Markers of tuberculosis, markers of HIV. Okay, markers of rheumatic heart diseases. You can go to the next slide.
Okay, sir. Vitals, pulse will be 80 beats per minute. It's a regular rhythm, high volume pulse. It's felt equally in all peripheral vessels, and there is no.
Usually, when I'm commenting about volume, you say whether it's a large volume or a small volume. Don't say high or low volume. Okay. It's a
Yes,
large
sir.
volume pulse or a small volume.
Okay, sir. And there is no radio femoral delay and no radio radial delay, and it's in a water armor pulse, sir. And blood pressure, BP measured in all four limbs. In left upper limb, it will be 140 by 10 millimeters. Systolic BP will be 140, diastolic will be 10 millimeters of mercury. In right upper limb, while measured in sitting portions, the systolic BP will be 140 and diastolic will be 70. In left lower limb, measured in prone position, BP will be 170 by 60. In right lower limb, measured in prone position, the BP will be 150 by 80, sir.
Okay. So what do you mean by water hammer pulse? What's the other name of that?
It's a Corrigan pulse or a collapsing pulse, sir.
Okay. Describe the pulse.
It's in a rapid upstroke with the yield sustained peak with a rapid downstroke, sir.
Very good. Where do you palpate for that?
Uh, for a radial artery, sir.
Very good. In the radial artery. Okay. So in case, what kind of pulse you can get? What are the different kinds of pulses that you can get? What is pulsus magnus? What is pulsus parvus septatus?
Slow rising late peak, sir. It's in a low amplitude
volume.
pulse with
Low
low volume pulse with slow
volume,
rising and
slow rising, late peaking pulse.
late peak,
The
sir.
opposite that is pulsus magnus. That is a large volume pulse. Okay, large volume pulse is otherwise known as pulsus magnus. And severe aortic regurgitation, we can get any other pulse.
Pulses bisference we get, sir.
Right. Okay. So how do you define that pulsus bispherians?
In we get a single pulse wave with two peaks in systole, sir.
What is the reason for the two waves? So you have every pulse, you will be having a percussion wave and a tidal wave.
Percussion wave.
So normally the percussion wave is much more higher than the tidal wave. So what happens in this severe aortic regurgitation is that this tidal wave will be either equal to the percussion wave or it will be more than the percussion wave. So naturally within a one systole you'll be having double peaking. Okay. So in severe aortic regurgitation or an aortic regurgitation with the aortic stenosis or in hypertrophic cardiomyopathy, you may get this pulsus bispherians. So aortic regurgitation, we can have three pulses. One is pulsus magnus, another one is pulsus bispherians, and the most specific as well as the most close pulse for aortic regurgitation is here, large volume water hammer pulse. Okay, right. So what is pulsus dicroticus?
It's a one peak in that's in one peak in systole and the other peak in diastole, sir.
Very good. So you should be knowing about the pulse wave, right from the central aorta to the dorsalis pedis. So usually the percussion wave, the upstroke will be very steep in the central aorta. While it is coming to the dorsalis pedis, the upstroke will be very slanting. It will be nearer to the baseline. Okay, so that is how the pulse is. And what is pulsus paradoxus?
Sir, fall in systolic BP of more than 10 millimeter of mercury during inspiration, sir. That is an accelerated fall of systolic BP more than 10 millimeter of mercury while patients.
You just catch hold of very specific places when it comes to definition. The exaggerated inspiratory fall of more than 10 mm of mercury is pulsus paradoxus. So what is the cause of reverse pulsus paradoxus?
Sir, HOCM
Very good.
and isorhythmic AV dissociation or intermittent P will have intermittent positive pressure ventilation also reverse pulsus.
Very good. So HOCM can have a reverse pulsus paradoxus, isorhythmic AV dissociation, and IPPV, intermittent positive pressure airway ventilation. Okay, right. So you have measured very good that you have measured all four limb BPs in sitting and as well as prone. So what do you infer from these measurements?
Sir, it shows wide pulse pressure, sir.
Very good. Wide pulse pressure. Why there is wide pulse pressure? Okay, we'll just discuss that afterwards. Right. Another anything that you notice in this pulse, I mean the BP measurements? What
Sister,
about the
diastolic BP, sir, compared to upper limb BP, lower limb BP will be high, sir. It's
No.
more than
So there is difference of more than 30 mm of venous
30
systolic
mm.
BP.
Yes, sir. And diastolic BP, it went even up to 10 mm of mercury, sir.
Right. Okay. Can proceed to the
Sir,
next.
okay, sir. Respiratory rate will be 18 cycles per minute. It will be regular. Abdominothoracic type, and no accessory muscles of respirations were used, and temperature will be 98.2 degree Fahrenheit, and saturation will be 97% in room air, and jugular venous pulse is not elevated, sir.
Okay.
So shall I move to next slide, sir? Okay, sir. The peripheral signs for when we look for peripheral signs for air, eye volume pulse, eye volume collapsing pulse, or Corrigan pulse will be seen. That's a water hammer pulse, and the locomotor brachii will be present, and white pulse pressure.
What
that
is
is
other
na
cause
eye
of
systolic
locomotor brachii?
atherosclerosis, sir.
Very good. Senile atherosclerosis. In old age individuals, you can have that locomotor brachii. It doesn't mean that the patient is suffering from aortic regurgitation. Okay.
And pulse pressure will be more than 60 millimeters of mercury, and dancing carotids, Corrigan signs will be present.
Now,
and
you say why you are having this wide pulse pressure on high systolic BP and a low diastolic?
Sir?
See which value? No, I am asking why this pulse pressure is so wide in this case.
Because of diastolic runoff in backflow of blood into the left ventricle, sir.
No, there's larger cardiac output as well as a diastolic runoff blood to the peripheries. Right. Okay.
And visible pulsation in the suprasternal arch will be seen, and pistol shot pulse in the femorals, and systolic murmur and compression of the femoral artery proximally, and duracis murmur. It's a diastolic murmur and compression of femoral artery proximally will be seen, and Hill signs will be positive, sir.
No, diastolic murmur will be heard when the artery is compressed distally.
Compression distally,
not proximally. Okay. Right. What are the various peripheral signs? You have said about some signs. What are the other signs that you look in case of white?
So we look
whether
for
these signs are seen in the acute AR or a chronic AR?
chronic AR, sir.
Oh. Okay, chronic
Sir,
AR.
other signs will be lighthouse signs will be seen, sir. That is an alternate flushing and blanching of forehead.
Okay.
Demusset signs. That is an head bobbing with each heartbeat will be
You
seen,
just
sir.
finish.
And
You finish. You come from top to bottom. After the lighthouse
okay,
sign, what is other sign? What is Landau-Fish sign?
Change in pupillary size according to the cardiac cycle, sir. And Becker signs,
what is
retinal artery pulsations will be seen, sir. And Demusset signs, that's a head bobbing with each heartbeat. Following that, uvula pulsation, that is during systole, uvula pulsation will be seen. That is called as the Muller signs. And Quincke sign. Quincke sign can be detected by pressing a glass light of the patient lip or the patient nail bud, sir. And Corrigan signs, that is a dancing carotid will be seen. And locomotor brachii. And for a collapsing or a water hammer pulse, systolic BP, and pulses difference are Jurassic signs and Hill sign, along with liver pulsation for Rosenbach sign and splenic pulsation over the spleen. It's called Gerard signs will be seen. So these are two sign peripheral signs and aortic reconstructions.
Right, very good. So what is Minervani's sign? Minervanin's sign. Minervani. So when you keep the tongue depressor over the tongue, it will move up and down according to the systolic pulsations. That is known as Minervani's sign. And what is Denison's sign? Denison, Denison.
Pulsate and
Pulsation.
cervix, sir.
Very good.
Cervix.
Pulsations in the cervix. What is log sign? LOGUE. Log sign. So these are the various signs that this is just for curricular purpose. You may not find every sign in every chronic AR patients. So log signs, there is a pulsation in the sternoclavicular joints when this aortic regurgitation is associated with aneurysm of the aorta. Okay.
Okay, sir.
So there will be pulsations in the sternoclavicular joints. So that is known as log sign.
Okay, sir.
Right. So what are the other methods by which we are talking about jugular venous pulsations? The elevation of jugular venous pulse and what are other methods how you can say that the right heart pressure is increased. In other words, what are the other methods by which you can look for elevation in jugular venous pressure?
Sir, hepatojugular reflex to look for any impending right heart failures.
Right. Okay. Hepatojugular reflex. Okay. You can also look at the ventral aspect of the tongue, where you can have engorgement of the veins. If the jugular pulse pressure is increased, there will be engorgement of veins in the downside, that is the ventral aspect of the tongue. And when you raise the veins above the heart level, the upper limb veins, ask the patient to dangle his upper limb, you can have engorgement of veins. When you raise the upper limb above the level of the heart, usually the veins will collapse. But if there is an elevated jugular venous pressure, then naturally the veins won't collapse even if you raise above the heart. Okay. So those are the methods by which bedside methods by which you can see elevated jugular venous pressures. Right. So I have been talking all about the peripheral signs of aortic regurgitation, which happens to be only in the chronic regurgitation. Right.
Okay, sir. Sorry. So now,
So, okay.
just demonstrating general appearance and sir. It's visible supraclavicular and suprasternal pulsations. Awesome. Well, going for examination of cardiovascular system,
Yes.
session will start procedure. Inspection and chest wall will be bilaterally symmetrical. Apex beat will be visible at the left 6th intercostal space, which lateral to the mid-clavicular line while in sitting position. And suprasternal pulsation and supraclavicular pulsation and epigastric pulsations will be seen. And there is no precardial bulge and no sinuses, no scars, no dilated veins and no discharge. And there is no drooping of shoulder. Trachea appears to be in midline and there are no spinal deformity seen, sir.
Right. Okay. Yeah. Then move to the next slide.
Sorry. On palpation, all inspection findings are confirmed. Apex beat, which felt at the left 6th intercostal space, 1 centimeter lateral to the mid-clavicular clavicular line, which is hyperdynamic in nature. While during palpating mitral area, there will be systolic thrill present over the mitral area, and there is no parasternal leave and trachea in midline, sir.
Felt at the left axis interval lateral. Okay. Okay. So how do you say it is an hyperdynamic in nature?
Sir,
In other words, describe a hyperdynamic apical impulse.
Sir, it's compared to systole, it occupied more than 1/3 of systole and which more than 1/3 to less than 2/3 of systole, and it occupies more than one intercostal space, sir.
Yes. So it is a diffuse apical impulse occupying more than one intercostal space, and usually it occupies less than 2/3 of the systole. And usually for a hyperdynamic apical impulse, it will be shifted down and out. So it is due to any volume overload conditions or eccentric hypertrophy. All volume overload conditions may produce an eccentric hypertrophy, while a pressure overload condition may produce an concentric hypertrophy and a heaving type of Apical impulse.
Apical.
Right. So it was an associated with the, there was a systolic thrill over mitral area.
Mitral area, sir.
Right. Okay. Okay. So what are palpable heart sounds known as? So palpable murmurs are thrills. What are palpable heart sounds known as? Shocks. They are known as shocks. Okay.
Okay, sir.
Right. In which valvular heart disease you will get the largest heart?
Sir, largest
Heart. The massive cardiomegaly. Which acquired
mitral
valvular heart disease?
regurgitation, sir.
Oh, aortic
AR
regurgitation.
with the MR.
Aortic regurgitation. Okay.
Okay, sir. Okay, sir.
Right.
On a percussion, cardiac background within normal limit, and auscultation of the aortic area.
No. How do you say that the cardiac borders are within normal limit? So you said that there was a cardiomegaly. The apical impulse has been shifted down and out. Is it so? So it is not within normal limits. You have cardiomegaly, okay? Right.
Sir.
So what is the main reason for cardiac percussion in your curriculum?
To look for cardiomegaly, sir. To look for cardiac enlargement, to look for pericardial effusions.
To differentiate pericardial effusion from cardiomegaly. That's the thing. Okay. Now you were saying about the apical impulse. How do you differentiate an LV apical impulse from an RV apical impulse?
Sir, if LV apical impulse will be laterally retracted, so if it's a RV apical impulse, RV apical impulse will be, it's rotated and shifted laterally, and there will be a lateral retraction will be there, sir. If it's a LV, the apex will be shifted down and outward with the medial retraction, sir.
Right. Usually RV apical impulse you will feel at the G sternum, below the G sternum. Okay. You just keep the palpating finger thumb over the this is G sternum. You will keep like this. If it is going to touch the tip of the finger, it is an RV impulse, and if it is going to touch the pulp of the fingers, it is due to abdominal aorta. Okay. Right.
Sir. And auscultation over the aortic area, S1 will be soft, and there will be an high-pitched soft blowing early diastolic recursion murmur, which is grade 3, which is best audible in sitting and leaning forward position.
Usually you don't grade a diastolic murmur. Okay. Only systolic murmurs are graded.
Okay.
No, you say about both the heart sounds. Then you say whether any additional sound is. Then you say about the murmur. Then you say about any added sounds here. So S1 it was soft. Okay.
Okay, sir.
What about S2?
Then sir, it will be masked by bulbous.
When you talk about when you talk about S1's amplitude, intensity as well as splitting, it will be better heard in the apical area. Okay. On S2, whenever you talk about S2, it will be better heard over the base of the heart. Okay. So
Okay,
S1
sir.
is due to why it occurs?
A closure, sir, sir, it's due to closure of semilunar valve, sir.
S1.
Yes, sir. Mitral and tricuspid valve closures.
It is due to the closure of the atrioventricular
Mitral
valves,
and
or S2 is due to the closure of the semilunar valves. Okay. What they say is that it is not per se due to the closure of the valves, but due to the vibration set in the cardiohemic, both the blood that is contained in the heart. So that vibrations they produce that sound. They say like that. Okay. But all along we have been studying that the valves, due to the closure of valves only, we are having that sound. Right. Okay. We proceed. We proceed to the murmur in the aortic area.
So in aortic area, murmur will be high-pitched, soft blowing, early diastolic decreasing murmur, which is best audible in sitting and leaning forward position with the diaphragm of the stethoscope in expiration, and it's the murmur will be conducted to the carotids, connected to the both carotids with decreased intensity, sir.
This is a diastolic murmur or a systolic murmur?
It's in a diastolic murmur, sir.
Aortic area. Right. So proceed.
In pulmonary area, S1 will be here, and the loud P2 will be there. In a neo-aortic area, S1, S2 here, and the early diastolic murmur, which is here with reduced intensity over there, sir. That's the same murmur which here in the aortic area will be radiated to the neo-aortic area with the reduced intensity, sir.
Right. What is inching auscultation? Inching auscultation.
Sir?
Inching auscultation. Inching auscultation. What is Gulliver's phenomenon? Now, you said that the same type of murmur is heard over reduced intensity in another area. That's why I'm asking this question. So, as a postgraduate, you need to know about certain auscultation techniques. And one important thing, last time our HOD was speaking about dynamic auscultation. It may bring out some murmur and it may mask some murmur. Okay. So that is very important in any valvular heart disease. Like that, radiation of this murmur, that is also very important. So to find that, you have to go from one area to other slowly, by inch. That is inching auscultation. So what is Gulliver's phenomenon?
So right side of the heart, while during inspiration, the murmur will be increased. The intensity of murmur will be increased
No, that is Carvalho's.
on inspiration.
That is Carvalho's rule. So Gulliver's phenomenon is that the aortic events are better heard over the apical area. So you have an aortosclerotic stenotic murmur and a rough ESM, ejection systolic murmur, it will be better heard over the apical area instead of the base of the gut. That is an aortic area. That is known as Gulliver's. Okay. So it was very clear that is in early diastolic murmur that is heard in the aortic area.
So it's EDM murmur, early diastolic syndrome.
Right. Okay. Just go to the next.
On mitral area, S1 will be soft. Yeah, high pitch is soft, blowing pansystolic murmur of grade 4 is heard with the diaphragm of the stethoscope in left lateral position where the breath held in expiration. The same murmur which radiate to the left axilla with the decreased intensity, sir. In tricuspid area, S1 will be here, and the same murmur aired over the tricuspid area with the same intensity. Oscillation of the other areas like axilla, clavicular, intrascapular areas will be appears normal, sir.
Right. What about the conduction to carotids? The diastolic murmur was conducted to the carotids.
And aortic area murmurs will be conducted to the carotids, sir.
Usually, systolic murmurs will get conducted. Right. Okay. You finish here, please.
Other system examination, respiratory system examination, bilateral R entry will be bilateral R entry present, and there will be normal vesicular breath sounds here all over the lung fields. The patient will have supraclavicular hollowness and inflow clavicular wasting, and trachea deviates to the right side, and
supraclavicular hollowness and infraclavicular wasting in what side? Both the sides.
It's seen in both sides, sir.
Okay, but the trachea is deviated to the right side. Minimal deviation or somewhat major?
It's a minimal deviation to the right side, sir. It's a minimal deviation to the right side, sir.
Okay.
And fine inspiratory crepitation present in the left supraclavicular, left infraclavicular, and left supraclavicular, infraclavicular, and infrascapular and interscapular areas, sir.
Find end inspiratory or mid inspiratory crepitations?
End inspiratory crepitation, sir.
Usually end inspiratory crepitations, they tend to happen at the base of the heart. So when does an end inspiratory crepitation happen? When your alveoli are filled with any fluid. So it usually occurs in the dependent part, that is your base of the lungs. But for fine end inspiratory crepitations to be in the left supraclavicular, left infraclavicular, left infra and intrascapular, we mean to say Both the lobes are affected. The upper lobe as well as the lower lobe on the left side. So this supraclavicular infraclavicular says about the apical segment of the upper lobe, as well as left intrascapular says about the posteromedial as well as lower basal segments of your lower lobe. Is it so? So whole of your left lung is affected. But the
Sir.
trachea seems to be deviated to the right side. Right, okay.
Abdominal examination.
You said that the patient was a smoker. Is it 10 years in the back years, 10 years or 40 years or
It's
something?
40 years,
Right,
sir.
right. No.
And for abdominal examination, there is no distension and the flanks were built free and the skin over the abdominal umbilicus in midline and it's everted and all corons are moves equally with the respiration. And palpation, there is no superficial palpation, there is no warmth, and deep palpation, there is no tenderness and no organomegaly. Percussion, the liver span will be 12 centimeters. Auscultation, bowel sense will be present, and there is no buoy and there is no venous hum, sir.
Right, okay.
In nervous system examination, iron mental functions will be intact, cranial nerve examination will be normal, sensory, motor, and cerebral system examination will be normal, sir. And other system, thyroid will be no examination over the neck. Thyroid will be normal. Scrotum and anal orifice will be free, and the spine and cranium normal, sir.
Right. Okay, you can move on.
And provisional diagnosis, it's here it's a case of acquired valvular heart disease with severe mitral regurgitation or aortic regurgitation with the evidence of pulmonary artery hypertension, without evidence of heart failure and no infected endocarditis and the patient in sinus rhythm. And the possible etiology will be rheumatic or degenerative, sir.
Why do you want to put both rheumatic or degenerative? We choose between them.
So if it's a degenerative aortic will be common. So if it's a mitral along with the aortic area with peripheral signs for AR, possible of rheumatic will be.
Right. So you have a multivalvular heart disease. So possibly for the both the valves to get degenerated at the same time, it's very rare. So you can say it is an rheumatic heart disease itself. Now, if the aortic valve is alone affected, what you can say? An aortic regurgitation.
Infected endocarditis, sir, or congenital. If
I'm saying
aortic,
the aortic regurgitation alone is there without mitral regurgitation. What are the possible etiologies that will be put in this 72-year-old male?
Quadricuspid valve, sir.
Which valve? No, first put degenerative, then rheumatic, and then syphilitic. Now, what is the three main differentiating features of syphilitic AR? It will be
peripheral signs.
No, chronic AR peripheral signs will be syphilitic. In syphilitic AR, it will be a rough murmur. Here you said that murmur was a soft blowing murmur.
And the Dumbo S2 will be there, sir. If it's syphilis, the S2 will be
that's
loud.
what I'm saying.
It's a Dumbo S2.
So it will be heard over the right parasternal area. Okay. So it will be heard over the right parasternal area. You will have a rough murmur, and definitely the quality of the A2 will be tambour-like. T-A-M-B-O-U-R, tambour-like quality. Okay.
Okay, sir.
Right. So what lesion you think is a predominant? As a postgraduate, you also say what lesion is predominant in this patient. Why do you think the patient has got to this much age without any symptoms? Possibly till now his left ventricular function would have been preserved, okay, with an aortic regurgitation. Aortic regurgitation, asymptomatic aortic regurgitation, they can move up to the 6th decade. Okay,
Okay, sir.
right. So we will keep it as a rheumatic etiology itself, since it is a multivalvular heart disease. Okay, affecting mitral valve as well as aortic regurgitation. And which lesion you think is a predominant lesion? Most probably
Yes,
it
sir.
should be an
Aortic
aortic.
regurgitation.
It should be an
Aortic
aortic
regurgitation.
regurgitation. Okay, right. So how do you proceed with this case?
Sir, we proceeded with the investigation, sir. We started with
No, because before that, what are the complications that you will expect in this case?
sir, for AR patients.
No,
Sir,
this
complication.
case, what complication you will expect? Dreaded complication.
Yes. Mm,
You should-
sir, if left ventricular output will be cardiac output will be low, sir. They are more prone to get syncopal attacks. Or sir, if arrhythmia will be more common, sir, or patient will more prone to get infected endocarditis, or if LV will be compromised, and more prone to get congestive cardiac failure, or heart block will be or heart.
No, that's what I
Heart
said.
block, sir.
Actually, I guess we know. Good talk. That's what I said.
Sir.
One is left ventricular dysfunction, other words, congestive heart failure. Next is the infective endocarditis. Third thing is the arrhythmias. Okay. What are the other murmurs that you can expect in the aortic regurgitation case? So you said that there is a soft blowing early diastolic
Sir,
murmur. How will you assess for the severity of the aortic regurgitation?
sir, severity of aortic regurgitation will be assessed because if the ill signs will be more than 60 millimeters of mercury, or if apical impulse is shifted downwards and outwards, and the duration of murmur, sir. If duration of murmur which occupies more than 2/3 of diastoles, and whisperance pulse, and peripheral signs, presence of peripheral signs.
Very good. So presence of experience pulse, the duration of the intensity, duration of the murmur, that is very important.
Murmur will be
So
occupies
initially, what
more than.
happens? Initially, what happens is that the murmur will be a short, early diastolic. As the regurgitant lesions becomes more and more and more, there will be more runoff, there will be more output. So the murmur will become long drawn. Okay, and as the severity of the lesion progress, again the murmur will become short. Okay, so the duration of the murmur is very important in case of and assessing the severity of aortic regurgitation. Okay. What will be the features of other heart sounds, S3 and S4, whether they will be present or not?
Sir, S2 will be loud and S3 will be soft, sir.
No, ma.
Uh,
Whether you can
sir?
have S3 or S4 in a case of aortic regurgitation.
If aortic if this patient went for failure, we can get S3, sir.
Right. One, S3 is due to failure. When the patient has gone in
Yes.
for LV failure means you can have S3. And if the patient is having a associated aortic stenosis or non-compliant LV irundaduna, you can have S4. Right. What are the
Okay, sir.
other murmur that you can expect in a aortic regurgitation?
Sir, Gregom still Austin Flynn murmur, sir.
So you can have an Austin Flynn MDM. That
Flynn
is a
murmur.
mid-diastolic
Yes, sir.
murmur or a late
Philip
diastolic
murmur.
murmur of across the mitral valve. Why does it
Yes, sir.
happen?
It's a flow murmur, sir.
So it is a
Flow
flow murmur that is
murmur.
due to the increased regurgitant blood will increase the end-diastolic volume in the left ventricle. So this increase in the end-diastolic volume will cause an increase in the end-diastolic pressure. To relieve that pressure, what happens is that even before the mitral valve closes. There will be a premature closure of mitral valve. In other words, this regurgitant jet will touch open the mitral valve and produce a flow murmur. That is known as the Austin murmur. It may be either a late diastolic or mid diastolic murmur. How will you differentiate this mid MDM, that mid diastolic murmur, from a mitral stenotic murmur? So we can say that it is a case of an aortic regurgitation with mitral stenosis. If there is an MDM in the mitral area, apical area, how will you say that it is due to MR or MS?
So it's a pan-systolic murmur with associated with the thrill, the same murmur radiated to the axilla, sir.
No, ma, I'm saying whether அந்த
Sir.
mitral stenosis-னால வந்ததா இந்த ஒரு MDM murmur கேக்குது.
Yes, sir.
There's some chronic aortic regurgitation where you hear an MDM in the mitral area. I am saying it is a murmur of MS. You are saying it is not due to MS. How will you clarify? How will you substantiate it?
In MS, the S1 will be loud, sir.
Very good.
But
That's
here
the
the S1
answer
will
I
be
expect.
softer.
So the S1 will be loud in MS and that will be associated with the opening snap. Okay. But always the mitral regurgitation, the S1 will be soft.
Soft, sir.
Right. Okay. So it is a case of an acquired valvular heart disease. Aortic regurgitation is aortic mitral regurgitation with the evidence of pulmonary artery hypertension without evidence of heart failure and infective endocarditis is a patient in sinus rhythm, possibly due to a rheumatic etiology. How are you going to proceed with this case? Now, what will happen if this is an acute MR? I mean, acute AR.
Sir, if acute AR will look for any trauma, sir, or a spontaneous bacterial endocarditis.
I'm asking about the pathophysiology of chronic AR and acute AR. What will happen to the heart in acute AR?
Sir, in acute AR, the patient will be. In acute AR, the patient will have symptoms of acute left heart failure with no peripheral signs, and the patient have no cardiomegaly. Along with the patient have diastolic thrill will be there, sir. And the patient will be symptomatic, like a patient will have breathlessness, chest pain, and the patient will look like a sick patient. In acute AR,
the patient will present himself as a hemodynamically unstable patient. Because the left heart won't have enough time to react to that very much of regurgitant lesion from the across the aortic valves. Okay, the patient will present to you with the hemodynamically unstable, and most often they will be mentally unstable also. Okay, I mean to say that you will have central nervous system findings also. It won't be mentally as well as hemodynamically stable. In chronic AR, you have plenty of time for the left ventricle to react, and it will have an eccentric hypertrophy, and so that it decreases the wall stress on this left ventricle. Okay, what is Laplace law? What is Frank-Stallings law in cardiology?
Suppose the force of contraction is directly proportional to the stroke volume, sir.
Force of contraction is? So the force of contraction of cardiac myocyte is directly proportional to the initial length of the cardiac myocyte, provided it is within its physiological limit. Okay, what is the length of a cardiac myocyte? It comes around 1.7 to 2 micron, I think. So it should be within its physiological limit. That is a very important catchword in that. So when the cardiac myocyte is going, the initial length is going to increase. Naturally, the force of contraction will also increase. That is Frank-Stallings. It is the principle behind which your hypertrophied muscles, they react to increase in any capacity of the ventricles. Okay, what is Laplace law? Now Laplace law states about the wall stress. So any hollow organ, any hollow thing, the wall stress is directly proportional to the pressure inside the pressure as well as the radius of the hollow organ, and is indirectly proportional to the tension on the walls. Okay, So whenever you increase the radius or increase the pressure inside the hollow organ, the wall stress is also going to increase. So that's why you get an hypertrophy. So whenever there is a chronic AR, what happens? The regurgitant blood will be filling again and again into the left ventricle, and the left ventricle will there will be an increase in the end-diastolic volume, which will increase the end-diastolic pressure. That is the wall stress. It will put more wall stress on that. So naturally, the radius is also increased, which means that the LV will go in for eccentric hypertrophy. Okay, but in acute AR, there
Okay,
won't
sir.
be any time for that. So naturally, the patient will present to you with an hemodynamically unstable status.
Yes,
And
sir.
as I said, there won't be any features of peripheral signs in
Peripheral signs.
acute AR.
And
Okay, right. And how are you going to proceed with this patient?
sir, we go for blood investigation, sir, to detect for any rheumatic carditis, or we go for ECG to look for any left ventricular
Oh, why do
hypertrophy or
you want to
conduction
look for
defect.
rheumatic carditis? The patient விட்டுருங்க rheumatic விட்டுருங்க.
Sir,
சரியா? Okay.
sir, and we go for ECG to look for any
ECGs.
left
What will
ventricular hypertrophy. Sir, இருக்கு sir. ECG will be there, sir.
the ECG ma?
Sir, it's an 12 lead ECG with normal standardization, sir. With rate will be around 75 beats per minute with regular rhythm, and with PV will be normal, and there is no there is no axis deviation. PV will be normal morphology. PR interval will be normal, and no acute ST segment and TV changes will be seen. And the patient will have a LV. Yes, sir. Here the positive findings will be there will be a poor RVS in lead 3, sir. There's a poor RVS in lead 3, and in
Right. You seem to have a low voltage complex in the limb leads, and you seem to have a mild LVH. Okay, and the
yes, sir.
heart rate is around 80. Okay, right.
Okay, sir.
Right. What other investigations that you look?
Sir, we go for chest X-ray, sir, to look for if it's a LVH, look for any cardiomegaly and aortic root dilation. It's a prominent aortic knuckles, and if it's in old age, to look for aortic valve calcification, sir. And after that, we go for echocardiography to look for to diagnose and also assess the severity and sir. After that, cardiac catheterization to look.
What is the role of echocardiography in a valvular heart disease?
To assess the severity, sir.
Then?
And to look for a surface area of the valve and for a diagnosis.
First thing you have to say is
and
to
look for any chamber enlargement and with any pulmonary artery hypertension.
Right. You can put it simply. First, to rule out any subclinical carditis. Not in this patient, any patient, any younger patients, you should rule out first subclinical carditis. And then you have to look for the morphology as well as the functionality of both the valves and chamber. What you said as a whole, it can be said in these 3 lines. To look for subclinical carditis, to look for the morphology as well as the functionality of both the valves as well as the chambers. Okay.
Okay, sir.
Right.
Okay, sir.
Oh.
And other investigation, cardiac catheterization to look for any coronary artery disease.
And another one important point is that with the echo, you can also it helps in it helps to say about the etiology also. How will the rheumatic valvular heart disease look like? How will the rheumatic heart disease valves look like? Or how does the senile, degenerative valves look like?
If degenerative calcification will be there, sir.
Very good. Mobility will be affected. Okay. How rheumatic valves la எப்படி இருக்கும்? Right. Usually rheumatic valves, the
Look for a mitral valve
commissural.
for any.
No. The commissural fusions will be affected. Okay.
Okay.
Right. Okay. And now we're going to proceed with this patient. You have done an echo. There is an PML prolapse, severe MR, left atrium is dilated, moderate pulmonary hypertension, moderate AR, caudal rupture. Okay.
The caudal rupture, sir.
Okay. So usually this patient would have been mitral valve prolapse patient due to the enlargement with the aortic regurgitation, due to the enlargement of the LV, possibly the cardia would have ruptured and it have precipitated on severe MR. Okay.
Okay, sir.
That's why the patient has been all along his life, he has been asymptomatic up to 72 years. Right. Right, we can proceed. So what are you going to do this with the patient?
So we for management, if it's an acute AR, we go for diuretics or IV nitroprusside, sir. If the patient's in chronic AR, the etiology will be due to rheumatic, we go for penicillin prophylaxis, or if it's a syphilis, we go for syphilitic arthritis will be treated. And beta blockers can be useful in AR if due to aortic dilatation, sir.
No. This patient, what are you going to do? Medical therapy and surgical therapy. So medical therapy, this patient, what you are planning to do? You can start him on AC inhibitors, ARBs. Okay. So it will help in decreasing his pressure as well as it will help in cardiac remodeling. Okay. What is the role of beta blockers in this patient? What is the role of beta blockers per se in a heart disease patient?
Sir, if due to aortic root dilatation, that time beta blockers will be useful, sir. In other words, beta blockers is contraindicated.
Beta blockers usually they decrease the central aortic pressure, but still they can produce bradycardia. So in any case of aortic regurgitation where the cardiac perfusion will be limited and there will be an increase in the demand for cardiac perfusion due to increased, LVH, you are going to increase the diastolic timing. Thereby, you decrease in the heart rate, you will increase the diastolic timing. So the cardiac perfusion will also be compromised because what is the reason for chest pain in aortic regurgitation case? Pathophysiology behind chest pain in aortic regurgitation case. One is the main is demand supply mismatch. You have an LVH, there will be more demand, but the supply will be less. Why the supply is less? Because due to the diastolic perfusion. Usually the heart receives blood supply during diastolic. There will be a decrease in the diastolic perfusion of your coronaries. The blood will run off drastically into the left ventricle or the peripheries. So there will be a decreased diastolic coronary perfusion. So when you are going to increase decrease the heart rate, the diastolic timing will also increase and there will be more runoff and the perfusion will decrease. So that was one of the reasons why you get a chest pain in aortic regurgitation. So with beta blockers, you are again going to decrease the heart rate, you are going to increase the chest pain. So in that way, beta blockers, it is always a risk-benefit ratio out of which the risk is more than the benefit for beta blockers. But AC inhibitors are the risk benefit is more.
Sir.
So you put them on AC inhibitors. And another important point is that In acute AR, the patient will be hemodynamically unstable.
Unstable, sir.
But still, the patient, even though the patient is in shock, he can use a vasodilator because to decrease the afterload. Okay. But it can't be
Okay, sir.
continuously used. See, in a patient with a shock, will you use a vasodilator? Usually, use an inotropic. அப்படிதானே? You don't use a vasodilator in a case of a patient with cardiogenic shock. But in case of an acute AR, to decrease the afterload, definitely you can use a vasodilator for some period of time, followed by inotropic agents. And then you can give a balloon counterpulsation and you can recover the patients. So in case of chronic AR, you go for a medical therapy. And this patient being 72-year-old, he has developed some symptomatology. You look for a left heart. You haven't said about the ejection fraction in this echo. So you also look for the ejection fraction, the systolic function of the left heart. When the patient is having aortic regurgitation, but it is asymptomatic, you can continue with the medical management. And the patient is having aortic regurgitation with symptoms, and you should look for left heart function. When the left heart function is not compromised, you can go for surgery. If the left heart function is compromised, again you have to go for surgery. In this patient, whether left heart function was compromised or not. He didn't have any symptom wise, he had only dyspnea. Other than that, he didn't have anything. Whether how was his LV function? Ejection fraction was around 50 or more than 50 or less than 50.
It's
So if it is going to be less than
more than 50, sir.
More than 50, you can follow up the case and then you can plan for a valvular replacement because it has affected both the valves. In multivalvular disease, multivalvular heart disease, which combination you will prefer? Affecting both the valves, your aortic valve as well as the mitral valve.
Repair of mitral valve followed by aortic area, sir.
If both the valves are affected, which combination you will prefer? Which means that which the combination the patient will be able to withstand for a longer time. Aortic regurgitation with mitral stenosis, because that back pressure won't be transmitted to your pulmonary vasculature. Okay. But in case of an aortic stenosis with a mitral regurgitation, it will be easily transferred. See, there is an aortic stenotic lesion. Your end-diastolic volume is going to, I mean, your pressure, LV pressure is going to get increased. There is always there is a mitral regurgitant lesion also. So naturally, this pressure in the LV will be transferred easily to the pulmonary vasculature and they will end up in pulmonary edema early. But in case of AR with the MS, the pressure won't be transferred to your pulmonary vasculature. Okay, so the better combination is an aortic regurgitation with the mitral stenosis, and the worst combination is an aortic stenosis with the mitral regurgitation.
Yes, sir.
I hope you understand.
Yes, sir. Yes, sir. The worst combination will be AS with MR, sir.
Right. So do you have any other doubts?
No, sir.
Does anybody have any doubt? Or else you can.
Thank you, sir.
All right. Thank you, Abhinaya. It was a very nice presentation.
Thank you, sir.
I have discussed some points that may be useful for the postgraduates. I thank our department HOD as well as the API Organization Secretary, our Vice President, for giving me this opportunity to discuss the case with the postgraduates. And I thank all the postgraduates who have participated in this discussion. Thank you.
Thank you, sir.
Sir, can we leave? So I see to that Palaniappan sir is not with us in this Zoom meeting. Right. I thank you one and all. Thank you. We'll leave this.
Thank you, sir.